Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do. Ta-da! Here we go. Kevin, what's up, bud?
Hey, Dave. What's going on, man?
Kev, is this a full circle moment?
Dude, this is pretty unbelievable. Yeah, this is pretty
Going from
wild.
listening to the shift show to being on the shift show 2 years later.
I know, dude. It's surreal. I mean, this is officially my first podcast, like, by myself, not on the Ask Mike Reynolds show.
Yeah.
I guess it's only fitting that it's with you. Kind of like the one constant in my PT career so far is Dave.
Definitely don't say that. That's dangerous.
Yeah.
Yes. So for those that are listening, Kevin and I are good buddies. I have the honor of working two chairs down from Kevin at the clinic, and we've been friends for a long time, but was a aide at a previous clinic a previous company we both worked at. Went to school, did a PT rotation at Champion, and then worked somewhere else. And then we got him a job at Champion, and now he works at Champion as one of our PTs. So we've come a long way, Kev.
Yeah, for sure, man. I know. It's like you never know where your life's going to end up. So it's pretty wild working next to you all the time.
Didn't you just have your 1 year anniversary, like shortly?
Yeah. Early July. So
Aww.
time flies, man. And it's been so, I tell you all the time, but it's just so fun working with you guys and, learned so much in the last year. So it's like you still feel like you're on clinical sometimes because you're just soaking everything up. But it's been awesome, man. Works great. Well, we have fun too.
Yeah. As someone who is 7 years now, I still feel the same way. I'm just like learning constantly and trying to soak it up. So if feeling is mutual, it doesn't go away, which is why it's a fun place to work out. Shout out Mike, Lenny, everybody else. Okay. So to the good stuff. I want to have you on because your expertise is for sure in running related injuries, which is something that you're, super competitive runner yourself. And the types of injuries that we see in running are also the types of injuries we see in gymnasts with impact. So as we'll talk about, running is just hopping on one leg, right? So there is impact related injuries. And I think people think that running is different than impact, but they're really the same. So with kids, we see severs and Osgoods and Shin Splints, which are gnarly for young athletes in general. We see a lot of young athletes who struggle with Shin Splints and Osgood Schlatters or whatever, but also obviously a lot of gymnasts struggle with that too. So I felt like this was a good overlap between the general athletic world to talk about it, but then also the gymnastics world. And then the second piece of it is, a lot of people who are mature, high school, college age struggle with more of like the post-growth injuries. So, patellar tendinopathy, Achilles tendinopathy, stress fractures, which are just the evolutions of what we talked about in the younger population. And then a lot of coaches, like a lot of just normal people out there that listen to the podcast that want to be in shape and want to run. They get all excited. They get their new shoes, they run, and they get gnarly shin splints, and they can't run because they unfortunately can't tolerate that. So I figured that by having this discussion, we'd have a nice catch-all of, younger and older, and maybe some advice on what to do there.
Yeah, man, that sounds great. And I think one of the things you said right there that people need to know is that running is like an impact sport. It doesn't seem that way when you just think about it intuitively, but just looking at some of the forces that go through the lower extremity with running, it's something you kind of need to be conditioned for. There's a saying that like when you're trying to run competitively that you need to be fit enough to train. And I think that there is some credence to that you have to have the ability to withstand stresses in the lower extremity, or things pop up pretty quickly, whether it's a bone injury or a tendon injury. We definitely see people who aren't ready to run that are gung-ho for it, which is awesome. Love that. But I think sometimes there's a little more education and guidance that need to go along with, this is a single leg hopping exercise. And if you're getting out some decent mileage, I mean, the number of single leg hops you do are, a ton. You might take 10,000 steps in a going out for like a 5 or 6 mile run. So there's a lot of ground impacts there.
That is funny to think about too, right? Like particularly in like the young sporting, think about like soccer or track or gymnastics, right? Like you would never just think about the number of impacts, but if you just sat there and jumped on one leg 5,000 times and your ankle started to hurt, somebody would be like, yeah, that makes sense. But like with running, if you go for a 3 mile run, it doesn't make sense. You're like, I just don't get why your Achilles is sore, but it's like kind of make it.
Yeah, for sure. Yeah.
And the other thing too, along that is, I'm just gonna get this out of the way early, is there's a lot of young programs, particularly gymnasts, that have like young gymnasts just going for like 3-mile runs on pavement. And man, with like a young growth plate related sensitivity, like that's dangerous, you know, doing thousands of impacts or thousands of runs on pavement. So I don't think you can't run, but there's definitely other ways to get conditioned that don't have such high ground reaction forces. So we can definitely dabble into that a little bit later.
Definitely. Yeah.
With that, so let's start here. Let's start about like why should we talk about running related injuries? Can't we just run through them with new shoes?
Yeah. Yeah. I think that's what we all need, is just a new pair of shoes. I'm a big Hoka guy, so go get some Hokas and just send it. Yeah. Yeah, man. So, you know, specifically with runners, I mean, I know we'll tie this all into gymnastics, but specifically with runners, if you look at the research, it's pretty scary how many runners get injured. And you'll see all different types of figures, and it depends on what population they're talking about. It depends on, you know, how they're defining injury, because sometimes it's self-reported injury or sometimes it's time loss injury. The statistics vary, but you'll see anything from 60 to 80% of runners report injury in a year, which is so high, right? That's insane. There was a really interesting study that I came across recently so they tried to quantify who's more at risk. And I think everyone always thinks it's the novice runner. And although rates in novice runners are very, very high, they looked at varying from short distance. So kind of track athletes doing, you know, 400 meter, 800 meter, all the way up to like ultra marathon runners. And you kind of see a U-shaped curve there where the people that are running tons and tons and tons of distance seem to be getting hurt. And people who do very high speed events also seem to be getting hurt.
Right.
But the injuries that you see in both are quite different. So people doing a lot longer distance seem to get more lower leg injuries. So I tend to think like below the knee, stuff like shin splints, which we'll talk about, Achilles tendinopathy, patellar tendinopathy, and then people who are more on the sprinting side. So I'm sure you see some of these injuries in gymnastics, but more like hamstring strains or hamstring tendinopathy type stuff popping up. So, you know, I think more research needs to go in figuring out why runners are getting hurt at such high rates. I think a lot of it comes down to training error and really just like not having intelligent training. And there's a ton that goes into that. And you can do all the right things, right? And injuries can still occur. But those numbers are so high. And I think a lot of it's kind of the overzealous programs that, you know, if you're training for a marathon, you know, you want to do, you know, you see programs where people are running 2 or 3 days a week and just doing high intensity. And for that type of event, that's not going to cut it. And then, you know, on the other side, you see people come off of, you know, say basketball season, and then they go into spring track. Well, they're not used to running a 2-mile event, right? So I think a lot of it is these change in stresses, and program design might not be great. But regardless, I think we need to care about running injury because the rates are so high. And I think a lot of times, unfortunately, you'll see on social media, people even in the healthcare field saying that, you know, there's other ways to get fit. You shouldn't be running. Running's bad for your knees, running, you know, and it has all these stigmas around it, which is very unfortunate to see because it's such a healthy activity, mentally and physically. So I think we need to figure out why these injuries are occurring at the rates they are, and put more resources into studies to get a bottom line answer.
I would agree. And I think that you can definitely see that, you know, running in general is like the easiest thing to do without preparation. Like you can literally roll out of bed, put your shoes on, and like go for a run. And I think in any other activity, you know, people wouldn't do that. They wouldn't just like roll out of bed, grab a barbell and start front squatting. It's just not how it works. But like running culturally is just something that like you can do really easy, which is great, but also not great. But also too is, unfortunately, I think that running has such a unique vibe around it where like you can really like push and grind and try to like get an extra half mile or a mile or whatever. And then you don't feel the effects right away. It's cumulative either the next day or after a week. And I think a lot of these injuries we talk about are not one incident accidental, like, rolling your ankle in a pothole is one thing, right? Tripping over a mat or doing something landing weird is one thing, but like a lot of these injuries are slow burns. They're slow progressive overloads. And the message here is that if you are a coach or someone working with young athletes, is you have to be very, very cognizant of your programming leading up to what you want to add. There's so many places, football, gymnastics, soccer, where like literally preseason week 1, day 1, like, all right, you guys had a big rest season. We're going to hit it hard. We're going to do all these speed and agility drills. And then we're going to all go for a 5-mile run, or we're all going to do all these impact plyos. And the kids' shins just erode because they get like gnarly reactive shin splints. 2 weeks go by and the delayed effect of that workload spike shows up 2 weeks later. And they're like, well, we didn't do anything. Like we've been training the same we've been training, but like 2 weeks ago, you crushed everybody. and the adult version of that is like, you get this spur of motivation for many different reasons, possibly health, possibly some other negative reasons. You're like, you know what? I'm gonna get after it. I'm gonna do 5 miles every day or twice a week or 3 times a week. And like 3 weeks go by and you're like, I can't move. My Achilles is on fire. And I think running just has that weird cultural vibe around it to like, just like get up and go as hard and push yourself and grind, so to speak.
Yeah, man, you nailed it for sure. And those are things we see all the time as PTs, and you're so happy for the person that you're treating because they've had this inspiration. You said like sometimes it can be negative, but a lot of times it's positive. They used to be an athlete. They're really trying to channel that athlete that they want to become and they used to be, and they're trying to do something positive for their health. But when you look at, like you said, maybe they had a month or two of good training, but when you look at kind of the acute to chronic workload in their last 6 months or year, it's such a change from what they were doing. And you see the same thing in I don't know, I did cross country in high school. And every year it was insane how many of us would just get shin splints like middle of September. And I think a lot of that's not doing the summer training that was prescribed. So, you show up and the coach expects that you did it, and you're starting out with double sessions and, running 12 miles a day, way under fueling, because there's never conversations about fueling when you're younger. And then half the team sideline with a shin splint injury. And it's just, like I said, and kind of you mentioned, a lot of it comes down to how are you training and what's your training consistency? Because those big changes in volume or intensity for these types of injuries, whether it's a bone stress in kids, like the growth plate injuries, or in older athletes, the tendinopathies, it's a change in something that they haven't been consistently doing.
And that's such a big myth, right? In the youth sport culture in particular, is that it's the time off that is causing this injury. And in reality, I don't think the research reflects that. It's not the time off that is causing the injury. It's that rapid increase in the first day or week, because you're like, all right, you guys should be fresh. Had a week off. We're going to run 20. We're going to go super hard on our strength. We're going to go nuts on all of our conditioning. And it's that rapid increase that is what really elevates the risk of injury. It's not the time off. It's the poor planning and reintroduction of workload.
Yeah, nailed it. Exactly. Definitely agree with that.
And then past that too, would you agree that sometimes when people are in this kind of trifecta, it seems like workload mismanagement paired with nutrition issues and issues, particularly in long distance runners around like red S and like underfueling, workload issues plus underfueling with a cultural, problem around it, plus the resistance, no pun intended, the lack of adoption to resistance training, like that trifecta is probably the reality of why so many people have impact and or running related injuries in youth sports and in older, in my opinion. But this for sure happens in like long distance runners, right? Like the workload is crazy. They're terrified to, eat the right amount of calories to fuel these insane workouts. And resistance training is like, oh, if I lift, I'm going to be slower or add bulky mass. So would you agree? Is that not true? I'm disconnected from the running culture community, but is that true or no? It's definitely true in gymnastics.
True. And I think another thing with the crossover between gymnastics and running, especially long distance running, I think is body image issues. And we don't have to get too in the weeds into that. I'm sure we could talk about that for a super long time. But if you're getting into running as an older adult, say for health, fitness, maybe physique, if you're coupling long distance running and burning a lot of calories with activity and not fueling properly, or if you're doing it at any age, right? But if you're putting in all this work and the goal you have in mind is more aesthetic and you're not fueling properly, it leads to disaster. And it usually leads more to, I think, the bone stress injury, maybe even a bone fracture, which is, then you're going to be sidelined for a long time. And I think even though the intentions are good, people need to be educated on refueling and having some sort of plan with nutrition. And I think the other thing is sometimes we see people eat one way in the off season, and then they don't change any way that they're eating when competition starts and when practices start going double sessions, or they're adding all this increased workload. And if they want to perform and look the way that they want to look, they actually have to eat more. And I think, I don't know how we go about that, whether it's coaches have more education on nutrition, or part of kids' programs is there's some sort of nutritionist on board. But I think that's a big thing. Yeah. So I think you nailed it. I think that especially youth athlete, we see reds and stuff like that, and it's terrible. And I think most times could be avoided, because I don't think people mean to underfuel all the time. I think they just don't know that you're burning a lot more when you're training more.
Yeah, and I can for sure jump on that grenade and say that was 100% after college, after gymnastics, coming from an aesthetic sport, right? Like, and wanting to, whatever. Like, I had huge body image issues when I was a younger, like 22, 23-year-old dude. And I was just like, oh, I got it. I'll just won't eat and I'll run more every day. And like in my mind, like the distorted view was like, oh, I'll just get like shredded and I'll just be like, super lean. And I just lost all my muscle mass, and I felt like complete shit the whole time. Like my joints hurt, my back hurt, like my tendons hurt, like my bones hurt running. And I was trying to like just push an insane amount of caloric expenditure to the point where like I was probably like dropping like more than a pound per week. But when you try to drop weight that fast, a lot of that comes from muscle mass, and it comes from, unhealthy side effects. And so, yeah, if you join, like, we support people who obviously want to get into running and health and fitness to look better, feel better, whatever. That's what we do for a living. But if your timeline is not at a realistic 4 to 6 to 8 to 12 week mark, and you're like, oh, I'm going to drop 10 pounds in 2 weeks so I can go on this vacation and look good in my bikini or in my bathing suit, like, it's a terrible idea. And you're going to crush yourself being starving all the time. And you're also going to have just the worst experience with injuries, because you're probably not going to have the straight up caloric input to remodel the tissue that you stress when you run.
Yeah, so I think there is definitely crossover with the other piece you mentioned with strength training between gymnastics and running as well. I think for whatever reason, running seems to be lagging behind other sports in adopting strength training. And I kind of go back and forth on this. And if you look at the research, I think some studies show a big performance improvement with running, some not so much. But I think if you're an experienced runner, say you've been running for a couple of years and you have a high performance goal of racing and you're kind of crunched for time, maybe you strength train a little bit less. But if you're a novice person or a relatively new runner, I think adding strength training to the equation, it just helps keep those tissues conditioned so they're ready to perform. So you're not having the experience where you're going out and dealing with all these ground reaction forces that you're not used to. And if you're putting some work in the gym, at least you're priming these muscles to be ready for impact. And maybe adding some plyometrics and not adding too much at once, but in a sensible way that you're preparing your body to be able to handle running. So I think all those things, nutrition, strength training, body image stuff, are all things that need to be addressed in both sports.
Yeah. And I think this is a good natural progression to talk about, like the mechanics of running and impact, and like why strength training is important. We have to first understand what running really is and like what does running require. So can you maybe share a little bit on, what's the difference between running and just walking, and then kind of like within the, like what is happening at a joint, bone, tissue level that leads us to want to have certain injuries not pop up?
Yeah. So kind of basic difference between the two is when you're walking, you always have at least one limb on the ground. So there's always at least one leg support in that gait cycle. With running, we get what's called a float phase. So there is actually a period of time where you don't have either foot on the ground. And with that, you're accepting all load on one foot when you put your foot back on the ground. So if you look at the kind of biomechanics research, there's a lot of different numbers out there for how much force is going through different joints. I think that depends on speed, what surface you're running on, and that type of thing. But, you know, you see things anywhere from, like, in the Achilles tendon, you might get 6 to 8 times body weight going through the Achilles tendon with faster running, right? You know, your hamstring, it depends. I think if you're more on the sprinting side, you sometimes get up to like 8 or 9 times body weight. Patellar tendon, like 5 to 7 times body weight. So with all these forces going through the leg, you know, regular gait, you might get 1, 2, 3 times body weight, you know, whether you're walking or on flat ground doing stairs. So the forces are just multiplied because of that float phase, and then you're accepting load on one leg. So I think because of those increased stresses, those areas are subject to stress they're not used to being subject to in the normal gait cycle. So if we can look at what tissues are most stressed in runners, we can build strength programs to get those tissues to be prepared for running, right? So I think all runners can benefit from kind of the normal life movements, right? Like squat, hinge, push, pull, carry, just to be a well-developed person, and not just focus everything in the plane that we run in, but also there needs to be some accessory work for runners. And we'll take like past medical history into account. So like for me, I've had hamstring issues in the past. I just add additional hamstring strengthening and it kind of takes care of that. But if we think about like our youth programs, maybe we add in some additional calf strengthening, some hamstring strengthening, some glute strengthening, and just focus on some of these target areas that are getting a lot of stress that we see in running.
Yeah. And I think also your youth sports in particular, right? You think about basketball, volleyball, football, gymnastics, right? They have this combination of sprinting and running combined with impact. And so the same tissues that you mentioned, like the patellar tendon in particular, the hamstring tendon, the patellofemoral joint, Achilles, like they're kind of getting a double dose here where they're getting stressed with sprinting, with running speed, but they're also getting stressed with impact. And I think that's why we see such high rates of injuries in these younger athletes, is because of the kind of double-edged sword here. And so while it's good to note that, the other piece of that is that that's why strength training is even more important, because not only do we know that strength training and the proper dosage of resistance training can increase your vertical jump and increase your sprinting speed, it can also condition these tissues to have more tolerance to some of these really high capacity type impact volumes. And so I think that's like it always comes down to the fact that the proper dosage of strength conditioning, if done with the sport in mind, can be a dramatic injury risk reduction and performance elevation. And that's why we're such advocates for doing it and slowing down and spending more time in like balance of model, not just doing year round, you know, 4 sports nonstop or running year round, stuff like that, gymnastics year round, because like what you lose if you're not prepared for the forces is far worse than the alternative, which is just clawing your way through it and getting hurt.
Yeah, definitely. One thing I want to sneak in here that I've heard Chris Johnson talk about a lot, if we're talking about bone health specifically, is it does seem advantageous for these youth athletes to be playing multiple sports. It does seem like if you look at ball sports, kids that play, you know, basketball, soccer, volleyball, like you mentioned, subjecting your bones to different stresses, so where you're not just running in one direction, it seems to build stronger, healthier bones. Those kids have higher bone densities. So maybe later in life, sports specialization is key to performance, but early on, you can balance a couple of different sports. You're building a better bone system for your life. And that's why, you know, even with our strength and conditioning programs that they write here at Champion, people are moving in all different directions, and we want to hone in on sport specificity, but also just general life movements are key to, if you're not playing other sports, are key to developing a healthy skeletal system.
Yeah, we were joking with Christina was on an episode recently. Christina Meyer, she's a strength coach, and we were joking how funny it is to watch gymnasts try to skip sideways or do anything sideways because they're just like not used to it. And so if you have a sport like gymnastics or volleyball's like this too, actually a little bit, but if you're just running straight ahead and up and down jumping, like you're losing out on a lot of conditioning and strength work for your lateral hips and for your bones to be stressed that way. which is why I think we see a lot of these injuries start to come up in the ankle in particular and stuff like that, because they're not used to those rotational and shearing stresses. So the addition of adding some general cross training and general weight training is that you're probably going to experience a bigger variety of forces, which overall will get your bones and tendons stronger, which allows you to train more, which is what everybody wants.
Yeah, for sure.
So let's go first talking about, I think that unfortunately gymnasts, one of the first things that Duesh does and Savannah do at Champion is fix how people run, because they literally have never got taught how to run correctly. So I think this leads into the conversation of like, when you're watching someone run, like, I don't know, as you as a PT, is it like cringy for you to watch like recreational runners out on the road? Sometimes you're like, oh, that doesn't look great. But
yeah, man, it's wild, because you do see some people, you know, you'll be slogging through in a race feeling like, you know, you're getting tired, you're towards the end, but you're like, I'm running strong, I feel great. And someone just blows by you with like the worst running form you've ever seen. It's like such a downer. But I think in terms of like gait analysis, kind of what we were talking about earlier, I think there's a lot of other boxes that we have to check first. Like, are you eating enough? Are you sleeping enough? Is your training program sensible? But then looking at someone run, there is some things that I would change in a runner if they were coming in looking for advice on their running technique. And I think taking their past medical history into consideration, right? So if you're someone that has like a glute med tendinopathy and you've got this crossover gait, you know, there's something quick we can do to work on that. If you're a runner who has some Achilles tendinopathy and you're running on your forefoot, there's something we can do to work on that. And I think a common thing that most runners have deficiency with, that if you fix this one issue, I think it goes a long way in making you a lot healthier runner, is looking at cadence and step rate, right? So there's been a lot of research surrounding this, and it seems like if you adopt a higher step rate, it seems a little paradoxical, because you're taking more steps. You would think that you're putting more stress through your lower extremity. But if you adopt a higher stress rate, even 5 or 10% higher than your normal cadence, we see something like a 10 to 15% reduction in the forces going through the lower extremity. So if you have someone with these chronic issues and you are watching them run, and I think most recreational runners that I've performed gait analysis on fall somewhere between like 150 to 160 steps per minute, which is really low. And what you'll see with that type of running gait is you see overstriding. It tends to end in a heel strike because they're overstriding and they're not going to just reach down with their forefoot, because that feels super weird. You might see a lot of vertical oscillation, and you just see a lot of slogging. If you're taking bigger steps, slamming down with your heel, it tends to be louder. So all those things can be cleaned up pretty easily by increasing your cadence. So generally start, and also I think this is important, I think in a lot of sports, is trying to look at how the most elite athletes in that sport train, right? So it's not that we can look at Kipchoge and say, I'm going to go run 150 miles a week like Kipchoge, or I'm going to run exactly like him because, you know, he's an absolute legend. But you can look at common principles, and common principles are most runners, elite runners, tend to have something around 180 steps per minute per cadence, right? So does everyone need that? No. Does some elite runners have 170 or 190? Yeah, but generally they're not in the 140s, 150s, right? So as a principle, if we can increase cadence, most people start to feel better with whatever issues they have going on. Very rarely I've seen increasing cadence be a problem. I've actually never seen it be a problem. And it can clean up a lot of these issues. And then other things that I mentioned, Chris Johnson, he's a great resource for runners and PTs that are interested in treating runners. But he talks about the S's of a gait analysis. So looking at strike, sound, step rate, speed, slope, shoes, shank, and step width. So we might see issues with each of those individually, but the overarching thing seems to be, if we can increase step rate, a lot of these other issues get cleaned up.
That's sick. I like those like very fluid mnemonics that he uses sometimes to keep you like going that way. And when you say these things about like step rate and speed and slope and stuff, it always reminds me of like you can run, like there's a difference between running and falling forward. Like there's definitely times when like you're running and you have like active, like thinking about hip position and arm swing and knee position and stride length and step gain. There's other times when I think people are just literally like flopping forward. They're just like leaning into gravity and they're just barely surviving falling over. Like if you want to be either performance wise, whether you want to have a faster sprint or you want to have better mileage or you want to have more successful, you have to actually be engaged when you're running and not just flopping all over the place versus, you know, I think sometimes when people just kind of like expect to just do the bare minimum and get the most out of it, you do have to actually think about where your feet are, where you're leaning, where your trunk angle is, where your like your step rate is, stuff like that. So that's just an important, you know, I guess caveat to remember is that there's a way to run that's not perfect for everybody, but there's definitely some technical pieces like you should be aware of.
Yeah. Yeah. And I think an easy thing for people to figure this out is, I mean, and I think this applies to gymnasts too. Like if they're going out on a conditioning run, whether, you know, say they're running, I don't know, a mile or two, if their coach wants them to start doing a mile or whatever. If you look at, you know, it's as simple as running for a minute and counting how many times one foot hits the ground, right? So, you know, I'll do it on myself every now and then. I'll look at my watch, 30 seconds, say my left foot's hitting the ground 40 times. I can, you know, multiply that by 2. All right, I might be having like a cadence of about 160 right now. That's a little slow. So maybe I'll speed it up. And for gait retraining, I think a useful piece is download a metronome app and just like practice, right? Don't go crazy. Don't go from like 150 to 180 because it's going to feel super weird. And you're actually less economical running at a different cadence, right? We're most economical at the cadence that we usually run at and the speed we usually run at. But over time with different types of training, you'll get more efficient at that higher cadence. So I'll start about 5% increase and have them just run to a metronome, you know, take it out for a training run and try to get used to that new feeling. And most people report if it's their first time doing something like that, like it feels way better, right? It's just, it feels more natural. You're not just, like you said, falling forward and almost like breaking with your feet. You're finding a better gait cycle. It feels good.
Yep. I dig it. This is great background information. I think now I kind of want to pivot into thinking about, all right, like we could go for days on technique and all that kind of stuff, but people usually find the podcast because something's not going well and they want to fix it. So let's talk about youth injuries first. So people who are under puberty, pre-puberty, you know, a lot of young athletes, a lot of gymnasts, a lot of kids, baseball, soccer, whatever. Let's maybe talk about a few of the most common growth plate and or youth injuries, what they are, and then things that you have found helpful to fix those.
Yeah. So growth plate injuries, unfortunately, are super common in youth. Like at Champion, we see a ton in the arm with baseball players. But in runners, we tend to see kind of two different ones pop up. So we see Seaver's disease, it's commonly called. And with that, we have, you know, just a little anatomy. So you have your calf muscles, your gastroc and your soleus come down and attach in a tendon called the Achilles tendon, which then attaches to your heel bone, your calcaneus. So when we're growing, all of our long bones have an area of cartilage known as the growth plate. That growth plate is laying down new bone and making your bones bigger. When we're doing a repetitive stress like running, and we're getting a lot of repetitive stress on something like the Achilles tendon, where we're pulling at that growth plate at its attachment site. And the growth plate doesn't like that, and it can become inflamed and cause pain. So for Seaver's specifically, what the patient will report is heel pain right at that attachment site. So it's not up in like the mid portion Achilles that you see with older people with Achilles tendinopathy. It's more on the attachment site where the Achilles attaches. So unfortunately, kind of what I've found, and I'd like to hear your thoughts on this too, is a lot of symptom management is what we got to do. And they got to kind of just get through this stage where they continue growing and things will settle down. It's not a lifelong pain that they're going to have. But early on, I think the first things that you want to do is looking at how can we alleviate some pain for this person and how can we adjust their program so they're not killing themselves and making this pain worse. So the first thing I do is talk to them about their program and talk to them about their pain. So figure out how intense is the pain they're dealing with right now. As a general rule for bone injuries, it's okay to work through a little bit of pain. the research talks about a 1 or 2 out of 10, but really not going above that. It's different than a tendon pain where you're okay to push through it, maybe like a 4 or 5 out of 10, if 10's the worst. We really want minimal pain, but I don't think no pain is attainable in a lot of these cases. So we want them to be very sensible. So first educate them on, this is the type of pain that's acceptable. Don't crank through this. It might be a case where rest is the best option for the short term, and work on other things, whether that's calf strengthening, whether that's strengthening up the chain, let things calm down, and then gradually reintroduce stresses to the Achilles tendon. Things like running and jumping are going to be the big things that stress that. Mistakes I've definitely made with this. So tendons, I guess this would become a tendinopathy in an older person, right? So these types of stresses that go through the Achilles tendon here are going to be running, jumping, things that put a tensile stress on the tendon, but then also a compressive force. So if you picture like you're standing on a stair step and you let your heel drop off the step and you're giving yourself a good calf stretch, in that position, we're compressing the tendon. And we're causing a lot of compressive force kind of through the tendon, through the growth plate. So I think early on, it's people want to stretch the calf. I think in some cases it might be irritating the growth plate a little bit more. So, I'll have them do, if the calf tightness is something we find on exam, maybe they do a little foam rolling to the calf. Maybe they do a little rubs ball to the bottom of the foot and give the muscles around there some love. And then there's little things that they can do to help reduce pain. So sometimes putting a heel lift in their shoe might help. That takes the Achilles off a little bit of stretch, and they're not getting as much force pulling through the growth plate. Sometimes if you can look at their footwear, if they're wearing like a 0 drop shoe, they might feel a little bit better with a higher heel toe drop, right? So something, again, same idea as the heel lift. You're putting the Achilles on a little bit of slack, and maybe that makes them feel a little bit better. So once their pain's under control with some of those lifestyle changes, some of the soft tissue stuff that they might be doing, some of the accessory strengthening, then we get them back into training, but keeping the pain levels within reason, right? And that just, like I said, a lot of education on that for the athlete. And I think Osgood Schlatters is another, super common one, right? And I'm actually an Osgood Schlatters survivor. I got the bumps to prove it. So I know these can be super painful when you're growing up. I was a avid basketball player when I was young, and it just definitely crept up and started to bother me. But again, it's not a life sentence. I don't think, you're not going to have these forever if you're sensible about managing your load. And gradually getting back to the sport once the pain's simmered down. But I think the same rules apply for the Osgood Schlatters. So with that, we have your quad comes down, kind of wraps around the patella, the kneecap, and attaches to the tubercle on your tibia. At that attachment site is another growth plate. So Sievers and Osgood Schlatters, we have tendons attaching to a growth plate site. And it's that repetitive stress from running, jumping, cutting, that type of thing that's pulling on the attachment site and inflaming the area, right? So same protocol, kind of educate the person on this is an acceptable pain for this type of thing. Be honest about what you're feeling, and we can communicate about that so we can adjust your program accordingly. Let's work on any of the tissues around the area, kind of calm things down, and then gradually reintroduce load, get you back to sport in a sensible way where this pain's not, completely derailing you.
Yeah, for sure. And those are phenomenal explanations of kind of the basics of it. And I think it's important to kind of highlight here how, there's different variables of these stresses that come up, right? Whether it's high load or high volume or high range of motion, right? Like these things are all possibly going to put more stress through these growth plates. And so if you have someone who is doing high volume, they come back to their sport and they start doing a lot of running and jumping and impact too fast, too soon. That's a spike in workload. But also sometimes it really is about like these extreme ranges of motion. Like, when you're sprinting or when you're backpedaling and cutting, you put an extreme tibial angle through the ankle and it puts a lot of that compression around the Achilles into the growth plate. Gymnasts get this when they jump and land, volleyball players, basketball players. So the reason why some of these bone stress injuries are so problematic is because you're playing with fire in all these categories, which is the volume, the intensity, and then also the range of motion. So it's really important to, educate and back off those things that are provocative, but also I see commonly in growth plate injuries, the solution is do nothing, shut it down, go back, try it all. And like that's called riding the roller coaster. And if we don't have this, transitionary strengthening of the calf, of the shins in particular, with shin splints, as we'll talk about, the bottom of the foot, what happens is you jump back, spike the workload, and it flares up again. And then you're riding that roller coaster up and down. So just because you don't have pain doesn't mean there's no problem there and that you don't need to go through the steps of a rehab and a strength conditioning program, which is really hard for young kids to keep up with, which is, well, my foot doesn't hurt. Why can't I go back to gymnastics or basketball or running or whatever else it is?
Yeah, I think one thing I've learned from you, one of the many, many things, is this outline that we have for people returning to sport, right? So whether it's a surgery or it's something like this, we always call that phase one kind of like damage control, put out the fire, bring the pain down. Immediately after that, you got to start maybe in conjunction with that. If pain is pain is letting them do what we want them to do, we build in a strength phase, right? So a basic strength foundation. A lot of times when these kids come into PT, it's their first time dealing with an issue like this. So you're teaching them, here's how you take care of your calf. Here's how you take care of your lower leg. What's get you on a good strengthening program. Make sure you tolerate that, right? Because there's a spectrum of stress from getting up and walking around to sprinting full speed, right? So we got to check the boxes along the way. And like you said, if you just take someone out of sport and then they rest a little, they feel good, they go back, we skipped all the different steps in between, right? So phase one, kind of put the fire out. Phase two, build a little bit of strengthening. Phase three, let's add some gentle plyometrics, start reintroducing more of that stretch shortening cycle stress. And then phase four, make it very sport specific, return to sport. And if you're skipping steps along the way, you might get away with it once or twice, but you're missing all the important things that's going to hopefully prevent this type of thing in the future.
And I think, so from that, so we have severs, we have Osgood Schlatters, these kind of, growth plate related injuries. Can we touch a little bit upon shin splints? Because although I think it's both, it's for younger and for older. I think these general bone stress injuries, the shin splints, because I think, we can have posterior, anterior shin splints a little bit, but can you just chat a little bit about what shin splints are? And I think we've established why they occur, but a similar process of the rehab process is the same, but shin splints are sometimes a complete enigma to people. They're like, I have no idea. I just expect shin splints and I just deal with it.
Yeah. And that last piece you just said is I've heard a couple people say that recently. I thought shin splints was normal part of training. I actually heard Pope say that. He's every year, track season would come up and I was just expecting shin splints. So it was a normal piece of training, but it's definitely not, right? And because of everything that we've already talked about for stress. But so, yeah, I came across an interesting statistic that of all the different running injuries, it seems like shin splints are actually the most common. So about 16% of runners get shin splints at some point, which I'm sure the number's way higher than that. I think 16% is probably pretty low because every high school runner has ever done high school sports has had shin splints. So interesting. We're still not exactly sure if it is a bone stress injury or kind of a crural fascia issue where kind of the muscle is attaching to the bone. Maybe there's two separate things. Maybe both processes happen and we're still trying to figure out through the research what exactly is happening. But it seems like whatever it is, it's a repetitive stress injury where either the bone is undergoing some demineralization and it's becoming a little weaker, or the muscle, and it's mostly seems like it's your soleus muscle. So one of the calf muscles is pulling on the bone and we're getting an irritation of the fascia. Okay. So, shin splints are also known as medial tibial stress syndrome. So your tibia, that lower leg bone, your shin bone, happens in kind of the medial 2/3 portion. And it usually happens on the posterior side. So if you kind of, are poking your shin and you just roll your finger to the inside of the shin, that's where you'll notice the pain. And a big piece here, because it is so closely related to other injuries in this area, for diagnosis, making sure we are dealing with shin splints and not bone stress or more specifically like a bone fracture of the tibia, which is a high risk site and something that we have to definitely make sure it's not a full fracture. What the research says is the shin splint will kind of be an area of greater than 5 centimeters. So if you have a pinpoint pain on your shin bone that's like the size of an eraser, then that's concerning, and it's something that we have to maybe get imaging for. If you have a broad diffuse pain that's maybe 2, 3, 4 inches long along the medial part of your shin, we're thinking more, maybe this is shin splints. And the treatment's a little different, right? Shin splints are more, we treat, like we talked about, very similar to something like Sievers or Osgood Schlatters, workload management, and then progressively building up strength, plyometrics, return to sport type stuff. But it's not always a case where you have to stop running either. It depends how long it's been going on, and it depends how severe the pain is. But if you're not careful and you just push through it, which most people can't because it does get pretty painful, but if you do just kind of grind through it, maybe it will become a stress fracture. And that's definitely something that we don't want, because, then you're non-weight bearing for maybe 6 to 8 weeks, and it just becomes a whole process that we could have probably avoided.
Yeah. And I think that's the danger, right? In kind of what's the word? Downplaying, shin splints is like, that happens with like sever stuff too. And I was like, just growing pains, just keep working through it. You'll be fine. But yeah, to a degree. But if you completely ignore it and just say, keep training through it and you're fine, when you get a calcaneal stress fracture or a tibial stress fracture or a tibial tubercle stress fracture and a full fracture, it's like 3 months where you're out, because you have to take the time to rest and let the bone heal. Then you have to recondition the actual, strengthening, right? Because we like using a lot of local calf and knee strengthening, like calf raises or shin lifts or stuff like that, because it pulls on the bone and it causes remodeling in a healthy way. But that whole process, you're time limited by what bone remodeling timelines are. You can't just magically speed up like shin bone remodeling. You have to load it, take 2 days off, load it, take 2 days off. And then you slowly get up to bounding. Then you're bounding, then you take 2 days off. Then you're bounding, you take 2 days off. That process of reconditioning the bone or the actual growth plate takes a long time, because bone remodeling is there. So a lot of people will not realize, I think, like the severity of the issue, and they'll just think they can get through season, and then they're left with a boot or something like that in the off season. And that's super, super unfortunate.
Yeah. And I think another important piece here is, if you're unsure, I think it's always best to see a physical therapist or someone that can help you diagnose. But generally with these bone injuries, versus if we're trying to differentiate, is this more bony or tendon or muscle, bones don't warm up. So keep referencing Chris Johnson just because he's such a great resource. And we talked about his little like mnemonics, but he says TWU, so tendons warm up. Tendons warm up, bones don't. So if you're going out for a run and you're not sure, like, is this something I can really push through? Is this a tendon thing? Is this a bone thing? If your pain's getting progressively worse as you're running, it's probably more of a bone thing. And that's probably something we need to take more seriously from what can you train through standpoint. Versus like the tendon stuff, maybe we can train through a little bit more pain, but I think being cautious is something. And then when you're going through these things too, it's a good time to assess. In children, it's a little different. I think a lot of times it's just part of the growth process plus workload mismanagement. But in some other people, it might be time to have a conversation with the patient and make sure they're doing the other things we talked about. Are you eating enough? What's your diet like? Or is your weight been stable? Have you had vitamin D levels checked? Stuff like that. I think another big one is talking about, like, with women, are you having consistent periods? So if we're getting into the bone world, we got to be comfortable asking these questions and make sure that we're addressing all their needs.
And I think with that, can you maybe go through, because it used to be the female athlete triad, and now it's like more red S syndrome. And man, young gymnasts, young females, like a lot of young runners stuff, they get a ton of like sacral stress fractures, femoral stress fractures, shin stress fractures. This combination of, mismanaged workload, underfueling, and the strength conditioning piece of it does lend itself, unfortunately, sometimes where, like you said, if it's been like the second, third, fourth time you've gotten a repetitive stress fracture, like it goes beyond training volume sometimes, and people blame genetics right away. But like, there's actually a lot more conversation around bone mineral density on top of that kind of stuff. So can you maybe just elaborate a little bit on female athlete triad, now red S, about what those major things to be on the lookout for are? And then we'll kind of go into more some like treatment stuff.
Yeah, perfect. Yeah. So, I mean, these are definitely things that if you have I think, especially with runners coming in, these are questions that you have to be comfortable asking. So there's, female athlete triad, but there's also males now. The research is figuring out that they deal with very similar issues, right? So kind of to qualify for that, we're looking at bone density. So are they osteoporotic? That's one check in that box. Is there a low energy availability? So in terms of they're not taking in enough fuel. And with females, amenorrhea. So if they're having less than 6 periods per year, and that's something that you got to ask and get some history on, that's a big red flag, right? They're not having regular menses. We got to figure that out. And you're in a high risk category with less than 6 per year. And then even if it's 6 to 8 and it's not a consistent, monthly thing, that's something that we got to, be on our radar too, as more of a moderate risk factor. So those are the 3 things. With men, it's actually the same thing. And a question you can ask is, are you having normal, regular morning erections? Because you're going to see a decrease in male sex hormone with people who are dealing with this. And sometimes, they'll be like, oh, I haven't had one in 3 months. I thought that was normal, but it's definitely not normal, right? So as clinicians, we have to be comfortable talking about these things and putting it on people's radar that with high levels of training, we still need these normal processes to play out. So, as far as treatment, I think some of this comes down to having a good nutritionist on staff or dietitian on staff, where a lot of it is you're taking in less energy than you're expending, right? So we have to have someone who might be better suited than us to come up with a plan with that person and figure out how can we get this person to fuel for the activity that they're doing. If it's severe enough, it's got to be the case where we take some pretty significant time off of training, address these underlying issues. In getting back to normal bone density can take a long time, but the seed has to be planted that we got to start being a lot more diligent with fueling. And if there's psychosocial factors that go along with that, we have to have the ability to know that as clinicians, that might not be our what we're best suited to do, but be able to give this person a referral or a resource to address these issues.
Yeah. And that's so challenging, right? Sometimes you have to understand, when you are or are not the person expertise wise, or just the gender that's probably appropriate to talk with that person. So, you have to be able to, refer a female runner to a female PT, possibly to have those conversations on a more normal level, or a male to a male PT or whatever you're working with. But also too, sometimes people are just more comfortable having those conversations with doctors, with medical doctors in a closed room by themselves and not in an open clinic, obviously. So I think you have to understand and kind of dance that line of maybe your suspicion is starting to be high that something is concerning, and maybe you email the doctor and you say, hey, when they come back in and revisit, their 6-week checkup or whatever else for an MRI, can you maybe drop this and ask it because we're concerned about it? Or, maybe it's a parent who has that conversation or something like that that's more appropriate. I think you have to, it's tough. These conversations are really challenging, but at the same time, you have to understand there's multiple factors, right? And so in a lot of these situations, particularly what I deal with in young female athletes, is the surface level problem is a repetitive stress fracture, and that's the conversation. But one layer deeper is the bone stress injury, the red S, and stuff like that. One layer deeper is a mental health issue around body image and aesthetics, and on, that whole mental health component of external validation and what they body dysmorphia stuff. So you quickly go down the layers of oh, it's a PT orthopedic issue. Oh, it's actually nutrition and an endocrine issue. Oh, it's actually a mental health issue. And we need to find the right person and facilitate a conversation with how do we get this person in the right hands? Because if you try to attack the orthopedic issue without really addressing the mental self-reflective body dysmorphia or something issue, it's never going to get better. It's never, and that situation is clearly health first, athlete second importance.
100%, man. Yeah, very well said. it's amazing the crossover, I think, between the two sports, because I've heard you talk about these things for so long now with gymnastics, but that's the important stuff that as clinicians we need to be able to pick up on. And like you said, maybe we're not best suited to help everything, but I think that's the amazing thing about being a PT is we get to see these people frequently and establish good communication and kind of get to what's the bottom, the very bottom issue, because I think a lot of runners are left short in the service that they're getting, because they might be coming in with like a bone stress injury to their shin and be told it's because they're overstriding, heel striking, right? And you're just completely missing the boat on the cause, right? And it's not that with every person we gotta get their whole entire life story and
Sure.
find out all their fears and goals and stuff, but having this stuff on your radar is super important. And anytime bones come up, I think having the conversation at least a little bit about, has your weight been stable? Are you following a solid nutrition program? Are you sleeping enough? Have you had consistent periods, or are you getting morning erections? These are things that we have to ask if we're treating people with bone injuries.
Yeah. And to that point, if you frame it in a conversation and you, from the very beginning, set the stage as what are all the things you need for optimal recovery, it starts to be a little bit less of a weird conversation coming out with some of those more impersonal questions. But I think just personal advice, and sometimes when my kind of yellow flag goes up, I kind of have okay, this person's not getting better, and I'm talking to them like, all right, like, you're doing everything right in PT and you're doing that. Let's check the boxes on all the other stuff. Like, are you sleeping enough? Are you drinking enough water? Are you doing soft tissue care? Are you eating enough? Like, you just kind of like quickly build it into like, these are all the things. Are you managing your time? Do you have hobbies outside the gym that you're doing for your mental stress? Like, you build it into an overall conversation of like, progress is not work plus work plus work. It's work plus optimal dose of recovery equals adaptation. And it normalizes the conversation around this a little bit. And then once you obviously build trust, or you refer them to the right person, you can have that little like, okay, sleep looks pretty good. And you're definitely, taking the appropriate time off from training. Like, what about food? Like, eating enough? Like, do you feel like you have enough fuel? Are you dead at practice? Then you kind of move through that one. Like, what about water? Drinking enough water? Like, so it's not like you're just harping on body image and food. You're kind of just like overall care, optimal performance.
Yeah, amazing. Yeah, I think that sounds like perfect plan. Like, you don't have to go gung ho asking these questions the first 5 minutes.
Hi, my name's Dave, and I'm wondering if you have a normal menstrual cycle. That's probably a tough start.
Yeah, I don't know how well that would go, but yeah, exactly. Like, once they're checking the PT rehab side of things, and you're not seeing things changing the way you would expect in these cases, then it's time to poke and prod and figure out these other areas a little bit more. Yeah, I agree.
And on this, I think I'm going to pull up our notes that we have here, because it's actually a really helpful image that you put in our note doc here. So can you just kind of chat about these kind of like lower to higher risk, high risk, medium, low, just so people understand, like, okay, if they're complaining of this certain area, you should be a little bit more on the worried part of it, like, just because the process of it getting better might be bad, but versus those that are maybe not as high risk.
Yeah, for sure. So unfortunately, like, not all bone stress injuries are created equal. Some are definitely more important to pay attention to and rehab the right way and unload at the proper time, because whether it's like the amount of vasculature going to that area, sometimes these don't heal properly if you don't treat it properly, and you can have like long-term issues, right? So the big ones that we see in runners are kind of, in that column, right? So femoral neck, lesser trochanter, medial mal, I won't read them all, but navicular. So with these types of issues, these are high risk sites. And with these types of things, we're not training through pain. We actually have to unload the area. We have to unload the area for about 6 to 8 weeks. Usually they're in some sort of non-weight bearing, because we need the bone to heal. Absolutely. These aren't things that we push through. Medium risk, maybe we unload depending on how severe it is. Maybe we can train sensibly, like walk, if it's not causing symptoms. But here we're really using pretty strict, like 1 out of 10 pain at most. We have to be very careful about what the next steps are. And then low risk stuff, we might be able to train through this and we meet them where they're at. So, maybe this person, maybe they can tolerate very light plyometrics, but they can't tolerate running. So, okay, we'll meet them there. Maybe they can't tolerate any of that, so we're going right through strength training. But I think, I don't have these memorized off the top of my head, but I know where to look if I'm suspecting one of these things. If you're suspecting a bone stress injury in one of the areas of high risk, I think with your due diligence, you have to refer them for imaging, because you don't want to miss one of these. You'd rather have them, I think in these cases, you're suspecting femoral neck, you'd rather have them go get a negative image than you missed it, you allowed them to keep training, and now things are way worse. So depending on the site, we should care more or less about pain.
Gotcha. And then kind of on that note is people always want to know, okay, how long is this going to take to get over? So like, what's a realistic timeline for, we'll just go with most of these kind of growth plate bone stress injuries before we talk about a little bit of tendinopathy stuff. Like, what are you thinking timeline wise for someone who's got a moderate case? It's not super severe, but it's not nothing.
Yeah. Well, I would say it depends on where they're at pain wise. So say they, say they're, they can't run. Say they're at the stage where they really can't run without pain. I like to think about kind of what we were talking about. So there's phases I want them to go through till we return to run. And I might start this person if they can walk without pain, say they can walk 20 minutes without pain, 45 minutes starts to hurt. Well, if their goal is to run 3 days a week, early on, I want to establish 3 days a week of a walking program, right? So maybe this is something that over the course of 4 weeks, 4 or 6 weeks, we're building good strength. And then we're adding in a walking program consistently, getting up to, maybe 45, 60 minutes. If that stuff's tolerated well and they're checking other boxes in terms of, they're able to handle some plyos without pain. We're going through the strength phase, we're going through the plyo phase, then we start running. So I think in most cases, if they're not running when they start rehab, I'm thinking at least 4 or 6 weeks till we start a walk to run program, because I want to build that baseline of strengthening.
Yeah, that sounds good. And I mean, like you said, it's going to vary, right? There's going to be some kids, some people that they come right to PT early. They have a little bit of a start of an injury. They understand they want to shut down. They're going to progress through those phases faster versus you're going to have someone who just trains way too long, way too hard on a bone stress injury. And you have a full 6 to 8 weeks of in a boot, and then you got to rehab, and there's atrophy from the rehab. So like, it's a very large range. So I get it. I think we've exhausted growth plates and bone stress injuries pretty well. Is there anything else you want to mention on this before we go to like some adult kind of tendinopathy stuff?
No, man. Yeah, I think we kind of hit it. I think a lot of the same themes, like over and over and over. So
yeah,
hopefully people, got the big picture about sensible training and stuff like that, and they take bone issues a little more seriously, because we don't want to get these high risk sites getting to the point where they have a stress fracture.
Yeah. And just to kind of give it the quick summary there is like, if you have a bone stress growth plate, whatever, it's some degree of unloading from impact and from running, right? It's going to be some degree of resting, but you're going to need to go through local specific loading. So whether that's calf raises, shin raises, walking, all that kind of stuff, then it probably needs to progress into so like probably like 2 to 4 weeks of deloading, 2 to 4 weeks of local strengthening and kind of figuring out what's going on around, and 2 to 4 weeks of compound strengthening. So step ups, split squats, RDLs, sleds, carries. We're big fans of that kind of stuff. And then 2 to 4 weeks of a gradual return to impact, which includes light plyometrics, then hurdle hops, and then jogging and skipping, and then higher impact stuff or higher volume running. So that's generally how I'd say most of the things we look at: calcaneus, Osgood, bone stress injuries with some degree of variability. That's kind of your roadmap. And I hate to say it, but like, yes, it's the same 8 weeks, whether you're in the peak of the middle of season and you have a big competition, or it's the off season and you have unlimited time.
Yeah, well said. Exactly.
Sweet. So what makes things different now when we talk about tendinopathies? Because typically when someone goes through puberty, when they have closed growth plates, now we're dealing with the Achilles tendon, the patellar tendon, the hamstring tendon. It's not so much the growth plate, it's the tendons themselves. Can you give people a little bit of a background on why tendons and kind of what's different about categories of tendinopathies versus just like a bone stress injury is like bone is inflamed?
Yeah. So I think an important thing off the bat is, like, you always still hear people say tendinitis. I think we've found through years of research that it's not necessarily an inflammatory condition, right? So these are kind of chronic overuse type injuries that we're seeing in tendons. And yeah, I think that a lot of these times the same mechanisms kind of apply, where if once the growth plate is closed, Now we're actually getting repetitive stress of the tendon. It's not just pulling on the weak growth plate. So we're seeing repetitive stress over time causing the tendons to become irritated. What's different about tendinopathies versus bone stress injuries is we can start loading right away. Tendons really respond well to strengthening. So, sometimes with bones, we have to unload. With tendons, we got to start doing whatever we can off the bat. Came across like a fascinating study where I wish I could have signed up for this study because I thought it was hilarious, but they took something like 8 to 10 healthy 20-something-year-old men, and they put them on 20 days of bed rest. And they looked at, that'd be sick. They looked at
paid to lay in bed for 20 days.
Yeah. Sorry, Lenny, I can't come to work. I'm part of this bed rest study. Yeah. So they looked at vastus lateralis and the gastroc, and the tendons there. So after 20 days of bed rest, you see a decrease in the max voluntary contraction. You see a decrease in stiffness. You see a decrease in the tendon cross-sectional area. So although pain might get better, you reduce all these properties of a tendon to make it healthy. And this was kind of paradoxical. It took me a while to figure this out. But in the research, when we look at tendons, we actually want tendons to be stiff. So people are like, oh, I feel stiff. I got to stretch. You actually want tendons to be really stiff from a kind of biomechanical standpoint. So you lose those properties of the tendon from overtraining. It hurts, you rest. Now you lose these elastic stretch shortening cycle properties of the tendon. And then you want to go back to running, and it's going to probably flare up again because it's not ready for the workload that you're going to put on it, right? So with tendons, the mechanism that we usually see, again, is some sort of change in volume or intensity. In runners, a lot of times it's adding, hill work. It's adding more up-tempo speed work that they're not necessarily ready for. Maybe they're coming off a rest period and they were doing all this stuff before, and now they think they can just plug right back in, and we see issues, right? So I think that, that's kind of, or sometimes even a change in footwear that, it's a different stress. I don't really think that there's good or bad running shoes, but if you're used to running in a 10 millimeter heel toe drop and then you go into a minimalist shoe, it's a big change, right? So there's some changing variable and the tendon's getting irritated. And that's usually what we see from a mechanism standpoint.
And then can you then expand into, okay, not all tendinopathies are the same, right? You have that like super hot, super acute happened right away. And then you have kind of what we've seen a lot of impact athletes, particularly older college athletes, which is like this long standing, I've had this on and off for multiple years. Like that's still, I think you're very right in saying everyone just says it's tendinitis. And then beyond that, they don't think about there's different classifications of tendinopathies. And of course, in my world, Achilles ruptures are the end state of that. But I'd like to kind of hear that summary from you.
Yeah. So exactly. Well said. So if I was to go out right now and throw 100 baseballs as hard as I could, I'm pretty bad at throwing baseballs. I'm sure I would get an acute, maybe tendinitis. Maybe there's inflammation in that type of case, right? I'm throwing as hard as I can and my tendon's just super jacked up. Maybe I go for a super long hike and I'm deconditioned and I'm not ready for something like that. So in that type of case, we have acute inflammation of the tendon or acute irritation of the tendon. And that is probably just a simple case of like, don't do that right now. Let your arm calm down. We don't have to go do that. Yes. I don't have to go do some like crazy rotator cuff rehab after that one day of being stupid. Just don't do that for a little bit. If that's something I want to do, I can come up with a sensible plan of how to get to 100 pitches, but that's more of the acute type tendon issue where it's usually just a little overzealous and you're doing something crazy that you never do. And with a little bit of rest, you'll be fine, right?
And that is the person who signs up for the 5K because their friends are doing it and they just like, suddenly get excited. Like the person who goes from 0 mileage to 5, 10, 15 miles in a weekend, that's the person who gets a reactive tendinopathy.
Yeah, exactly. Right. And I think from a PT standpoint, you got to figure out, like, is this a new task for the person or is this something that they've been used to, that they're used to doing? And if it's not, you just educate them, like, you're going to be fine, dude. You just don't go throw 100 baseballs as hard as you can and your shoulder's going to calm down in a couple days. Just be sensible with what you're doing next. Versus, when we're looking more at the chronic issues and, the stuff where you end up seeing Achilles ruptures, unfortunately. How many Achilles ruptures are on your schedule right now? Because like a couple weeks ago, it was like 6 or 8.
I have 6 right now. One of them came for just a one-time consult because she was like traveling and she was in town. But I have 6 right now. 2 are return to sport. 1 is about to start return to sport. 1's in the middle, and then the other ones are in like the earlier phases.
Yeah, that's sad.
All tears from last year's college gymnastics season. Everyone back answering takeoff.
Crazy. Yeah, so I think in those types of cases, what we're probably seeing is a low-grade irritation of the tendon over time, and it's something that maybe it flares up as the season progresses, and you kind of keep pushing through it because I'm sure there's a million reasons why, right? You don't want to lose your spot on the team. You think it's okay to push through. You're not sure if it's okay to push through, but you don't want to let your team down or whatever. So you keep pushing through, and then maybe you have a little bit of time off. The tendon starts to feel better, but then you go back to doing what you were doing. And it's just this chronic, I think like Mike Reinold always says often is like, there's a difference between chronic pain and chronically doing something to irritate your tendon, right? And I think in runners, we see this a lot with, they go through a training cycle, their Achilles tendon's jacked up, they take some time off, it feels a little better, they go back, and it comes right back. So, yeah, we have these 2 types of tendon issues, the acute irritation from something that you don't normally do, and then the chronic kind of low load irritation that we see in a lot of athletes.
Yeah, and a lot of times we're managing, like you said, those small bouts of repetitive re-irritation, but you do have to remember that you can't always prove this and show for sure. Typically what happens is when you continue to re-irritate it, it doesn't have a good healing effect. So it is continuously getting a little bit more dysfunctional, dysregulated tissue quality, whatever you want to say. Jill, the biggest thing that stood out to Jill when Jill Cook, when I talked to her, she said like healthy tendons don't rupture, right? So like it's years of progressive overload, and like these people who have really gnarly reactive tendinopathies or have really struggling with lots of pain, they think that like, oh, I just went out for this one run and it must have been these new shoes and I flared up my tendon. But it's like, no, this is like a much longer, slower progression of degeneration or irritation. So 1, you have to level set your expectations and know it's going to take a lot of time to get back safely. But 2 is that if you really want to have this not be an issue and keep running for life or playing your sport, you have to have a hard conversation with yourself about what does my workload look like? What does my strength training look like? What does my programming look like? Because you're going to keep doing just like the same kind of knucklehead thing and banging your head against the wall.
Yeah, exactly. Yeah, that's a good resource for a lot of people is checking out Jill Cook's work on tendons. Most of the things I think I've learned has been through research she's done. So, I think one other thing she talks about too is like, I'm sure you've seen it too, but you have people come in who maybe they were told before that their tendon is like dysregulated and, now they have this unhealthy tendon, whatever. But I've heard her say, sometimes there's more healthy tissue in a tendon with tendinopathy, if you rehab it correctly, than in people who never had a tendinopathy, right? So it's not a death sentence, and you can really build up healthy quality tissue in these tendons with a sensible approach. Yeah,
because sometimes you just need that small bout of tendinopathy or irritation to get to the right provider to give you an exercise or a strength program that's going to give you a healthier tendon long term. So I think that makes for sure sense. Okay, so we talked about how bone stress injuries are treated differently than tendinopathies because of the different underlying like pathology and tissue involved. So what's the treatment for a lot of these tendinopathies can be lumped together. So like a patellar tendinopathy or an Achilles tendinopathy or a hamstring tendinopathy, like what are the principles of rehab that we're going to treat these people with, like with earlier load, and what's that progression look like to get their tendon back to a normal quote unquote state?
Yeah. So I think, with these types of tendinopathies in the lower extremity, it takes a little nuance of the clinician to know what running stresses are putting on these different tendons, right? So if you have someone with, let's go with Achilles tendinopathy to start. So, 2 types that you want to differentiate as a clinician is this a mid-portion Achilles tendinopathy or an insertional? Because the way that you're going to treat it is very similar, but there might be a little bit of change early on. So I think of insertional Achilles tendinopathy, like the Severs that we talked about, right? So this is right where the tendon attaches to the bone. And although the same principles apply for rehab, so if we have to unload for a little, maybe we're unloading for a little bit, then we're, as soon as we can, getting into some sort of structured loading program. And then we're getting into some loading plus plyometrics, and then we're getting into some return to sport stuff. I think the only differences early on is if you have someone with a insertional Achilles tendinopathy, you're not necessarily going to have them hammer calf stretching, right? Because you're getting that same compressive force across the calcaneus, and it's going to actually make them worse. And I think some of the research has also shown that doing heel raise strengthening with a deficit for that population might also make it worse because you're getting that compressive force. So being able to differentiate what part of the tendon for these cases, I think early on is important, because maybe, again, the same principles as the Severs, right? Maybe we recommend a heel lift for a little bit. Maybe we recommend a higher heel drop, toe, shoe to begin with. And then with like a proximal hamstring tendinopathy, early on, again, tendons don't like a lot of strain when they're irritated, and they don't like compression, right? So we're not going to have them, even if their hamstrings are tight, we're not going to say, let's stretch the crap out of your hamstring, because you're going to get that compressive load, right? So I think a big piece early on is figure out what location the tendinopathy's in, and what do we have to educate them on for home, right? So proximal hamstring tendinopathy, it's going to hurt to sit. Maybe throughout the day, can you stand up a little more frequently, unload the tendon from this compressive force, and then resume more sitting over time when the tendon's less irritated. So there's a little nuance to specific tendons, but once we have a conversation about what they need to modify at home, we start trying to load as quickly as possible, because the tendons love load. That's another Chris Johnson, TLL, tendons love load. And to remodel the tendon and to make it, add more healthy tissue, we want to start loading as soon as possible. And I think the caveat here that needs to be very specific with tendons, according to the research, is it has to be a heavy load. And this is where I've been guilty for sure in the past of giving patients, underloading patients, right? So, we really have to work up to something like a 90% 1 rep max load to get the remodeling that we want. If that's too painful early on, or someone's not well trained enough to lift that heavy, that's fine. We can build up to that. And another very helpful thing for some people with tendinopathies is isometrics, right? So there's been studies looking at a protocol of something like 5 sets of 45-second contractions, something around 70% of effort. So doing this can modify their pain in a way that makes them feel better, right? So anything early on we can do to modify the pain, whether that's a combination of changing what they're wearing, changing what they're doing throughout the day, giving them some isometrics, and then teaching them how to move so we can quickly get to this heavy, slow loading, go through a heavy, slow loading phase, and then we have to restore what tendons are best at, which is the stretch shortening cycle, get into some plyometric training, right? And really give the tendon all these different stresses that it requires to be healthy.
Yeah. And I think there's a really important point you made there, which is like that, the need for higher load in these calf kind of knee kind of hip areas. I think people, unfortunately, particularly in like bodyweight sports or in some not available strength equipment, they'll do like 3, 4, 5, 6 sets of like 20, 30, 40, 50 calf raises, and they're just hammering calf raises. And what that's doing is that's causing metabolic stress, right? So you're building up acidity and you're causing muscle damage, which might make you sore, but it's not actually putting higher load through the tendon. And so what happens is then you go and you do sport forces, jumping and landing, basketball, volleyball, very high impact sports, and your tendon is not prepared for higher load at a faster rate. And so that's actually one of the things I recommend to all of the gymnasts that I work with in the college programs I consult with is like, in the summer, you want to be doing seated heavy calf raises, like with a giant kettlebell, or seated standing slant board calf lowers, or, tib bar, anterior shin work, type like that, because you want to locally train for not only metabolic work, but also high strain. And so you need both of those things, which is valuable. And kind of to wrap this up is you kind of have outlined a really good description for what to do with those kind of acute, kind of reactive ones. What is a starting return to plyometric program look like for you, just so we can come full circle on how to help people, and then we'll wrap things up.
Yeah. So some early things I like to do with runners or anyone returning to running is like pogo hopping. I think pogo hopping's fine. You're getting some good load through the tendon, and it's easy to control. It's easy to count reps of how many they're doing. So you have some starting point of, all right, session 1, we did 70 pogo hops, whether that's like double leg pogo hopping, maybe some out and ins, some scissors, a little like multi-directional stuff. That's kind of like an initial session. And then we can add that, add a little bit more over time, so we're increasing how much they're doing. As we get a little bit more specific, we might be doing things like A skips, B skips, C skips to mimic running a little bit more. And then as we want more and more load to go through the tendon, we can do stuff like box jumps. We can do stuff like broad jumps, depth jumps. So, having some background in how much force is going through the lower extremity or the tendons with different types of plyos, they're not all created equal. So, a max squat jump, you're putting, maybe 6, 8, 10 times body weight through the tendons versus pogos, might be 2 or 3 times body weight, right? So we're starting sensible and seeing what they can handle. And then, they come in for a PT session. We start with pogos, do 100. All right, that goes well for a week. Next week, we do maybe 200. And they're like, this is easy. This is fine. All right, let's add in some more sports specific stuff, maybe some skipping. Assuming that goes well, now let's get into some, higher level plyos and make sure that you're really tolerating that, lateral bounding, forward bounding, box jumps, depth jumps, kind of throwing everything at them and making sure that the tendon's where we want it to be, I think is a sensible progression.
I dig it, man. I think we have sufficiently crushed it. That was a ridiculous amount of information in an hour and a half, even given our internet lapse. But yeah, dude, thank you so much. Where can people find you more for information on socials that you're putting out a lot of good content lately?
Yeah, man. Yeah, that was a ton of fun. So I do lack on the social media game, but mostly because I'm busy at work and trying to learn how I can on my own, right? So, but my Instagram's Kevin Coughlin DPT. Definitely going to try to be putting out more stuff. I think it's always the case where like you feel like you don't know enough to put stuff out, and you're like, who's going to want to look at my content? But
yeah, well, from this podcast, I respectfully disagree because you have clearly content to share.
Thanks. I think, and it's been awesome, like learning all this stuff from you guys in the clinic too, and knowing who you guys look up to for resources makes it easy for me to look up to the same people, right? And, hopefully what I want to start doing, right, is putting out just stuff I'm reading. So, I took a few courses recently and just kind of regurgitating that information to not recreate the wheel, but just put out some like quality content, because I really think education is such a massive advantage for people, and with sensible training, you can get better at your sport, and you can hopefully prevent getting hurt. So I think, I'll be trying to put out some more stuff.
That's 100% how Shift started. Is I was insecure about not knowing it all, but I was like, well, this is what I'm learning. This is what I'm reading. Here's what I learned from them, but also here is, what my interpretation or how I'm using it, or, my spin on it. So yeah, that's a phenomenal way for people to create content, is not to think they know it all and be an expert, but more just like a humble learner. And I feel like that's still what I do. I'm like, this is what I'm learning. So I'm thinking about, this is like what goes on. I might have had some stuff from experience, but whenever I just like pick up new articles and stuff, I always try to just translate that a little bit.
Yeah, for sure, man. You've been putting out great content for so long. It's so weird to just sit here like talking to you. It's like I've been watching your podcast for like way before I started working with you, and then it's so weird to see like all you guys in the clinic. It's like, oh yeah, I work here too.
We're normal humans,
Yeah, no, it's crazy. Pretty cool, man.
I think it's always funny because people think we're so professional. Not that we're not professional, but they think we're like so like rigid and professional and like, tucking our shirts all the time and are super proper, and like we're so laid back. Like I try to be very chill and laid back. I think it's why people like coming to hang out with us. It's not this like sterile kind of boring PT place.
Yeah, it's only Lenny who's super serious.
That's definitely it. Shout out, Len. Word, man. All right, we'll get this chopped up, and then probably sometime next month it'll come out.
Awesome, man. I appreciate it.
All right, man. Thanks so much.
Thank you.